Khan for a wonderful presentation. I'm Dr. Shauna from Neurosurgery department. I'll go through classification of spinal trauma. Starting from introduction of traumatic spinal cord injuries. So it's a traumatic injury leading to damage of the spinal cord, which results in temporary or permanent change to neurological function, which happens because of the blunt physical force during trauma, damaging the anatomical structures of the spinal cord. So, majority of spinal cord traumas are caused by preventable causes, right, like road traffic accident, falls, violence, and also some sports injuries. More traumatic spinal cord injuries are more common in males compared to females. Going into pathophysiology of traumatic spinal cord injury. So here you can see pictorial representation. So once there is a trauma to spinal cord, this will cause vertebral fracture and it will lead to compression or dissection of the spinal cord, causing mechanical injury and then damaging neurons and oligodendrocytes in the spinal cord, leading to impairing communication pathways of the nervous system, which can cause complete loss of sensory or motor function. This phase is referred as the primary damage, which lasts from 0 to 48 hours. Then we will have an inflammatory phase in which there will be a release of inflammatory markers like tumor necrosis factor, interleukins, causing cascade of events like inflammation, ischemia, vascular damage, edema, and also cellular toxicity. This will go from 48 to 7 days, continuing from inflammatory phase to subacute phase. There will, during the continuation of this phase, there will be neuronal and glial cell death with formation of cystic cavity, and it will inhibit the regeneration and it will prevent the repair. So all of this process will lead to progression of neurological damage. Hence it is very important to identify spinal cord injury early and then do intervention in order to limit long-term damage to spinal cord. So to assess the neurological level and completeness of spinal cord injury, we use Asia impairment scale. It ranges in which we grade the injury from A to E. This will help us to determine the prognosis and monitor the recovery of our patients. So in case of Asia impairment scale, if patient has grade A to C injuries, then it is very important to go for early intervention in order to prevent deterioration and also maximum recovery potential of patient outcomes. So starting from spine injury classification, here we use AO spine injury classification. This is a standardized system developed by AO Foundation in order to have standardized terminology among surgeons to determine whether a patient's injury is stable or unstable, and also provide consistency in injury diagnosis and treatment. Anatomically, it is divided into 4 regions: upper cervical injury, subaxial injury, thoracolumbar injury, and sacral injuries. So upper cervical injury, at first it is divided based on site, which is occipital condyle and craniocervical junction, C1 ring and C12 joint, C2 and C23 joint. Later, then again it is subdivided into type A, where we will see only bony injuries, type B when there is involvement of tension, band or ligamentous injury, type C when we see any form of translation. So here you can see occipital condyle and craniocervical junction injuries from isolated bony injury to displacement on spinal imaging, where there will be craniocervical junction displacement. C1 ring and C12 joint here, so it is in similar manner. type A injuries when we see only isolated bony injuries, and type C when there is atlantoaxial instability. C2 and C2-3 joint also in a similar way, in which type C would be joint C2-3 joint translation with a disc injury. Second part, subaxial injury. Here subaxial injuries are classified based on morphology, in which type A is when we see compression fracture where there is only involvement of bones. Once there is involvement of anterior and posterior tension band, then it is type B injuries. Once there is a displacement, then it is considered as type C injuries. So starting from type A injury where there will be only bony involvement, it goes from minor non-structural fractures to complete burst where there is an involvement of both end plates. Type B injuries where we see tension band injury, where there will be only posterior tension band injury going just through the bones to anterior tension band injury causing translation. And last type C, is when there is a translation injury where we see excess displacement or translation of one vertebral body relative to another vertebra in any direction. Here we see facet injuries as well. F1 injuries are when there is only non-displaced facet fracture. 2 are when there is a bilateral facet injuries where we see BL injuries. F4 is when there is a pathological subluxation or dislocated facet. Going into thoracolumbar injuries, here in a similar manner it is also classified based on morphology where we see compression injuries, destruction injuries and translational injuries. So at first we have to check for most severe form of injury, which is type C injury, where we see translation injury, heavy dislocation or displacement of spine vertebral level from any direction. Type B injuries we see destruction injuries, so here it is from most unstable to stable, where we see hyperextension to chance fractures, and then incomplete burst where both end plates are involved. So type A compression fractures are when we see split fractures, and then it goes from most unstable to stable where A0 is only isolated fractures. Going into last part, sacral injuries. Sacral injuries are divided based on anatomical location where we see type A injuries only for lower sacrocoaxial joint injuries. Type B is when there is a posterior pelvic injuries, and then type C when there is spinopelvic injuries. Here you can see pictures from A1 to A3 of sacrocoaxial injuries. A3 being most severe form where there is a displaced transverse fractures below the S1 joint. Type B when there is involvement of posterior pelvic region. Most B3 being the transforaminal fractures, but in B3 there won't be any spinal canal involvement. Type C injuries we see in spinopelvic region where it ranges from non-displaced sacral U-type variant to sacral U-type variant without posterior pelvic instability. So here are the references, and thank you for listening.